would be, so the factors to consider would be revision risks, the PROM scores, and of course, the cost as well. I'm going to focus on revision risk because if we include PROMs and cost, then this presentation will become probably too long. So method of fixation first. So what's there in the NJR? And you can see that temporal data from NJR. And over the last 10 years, the proportion of hybrids that are being put in the yellow have increased, while the uncemented perhaps had its peak in 2009 and then steady, slow decline. And even the cemented hip fixation, there's been a steady decline. So hybrid clearly is the most popular combination in NJR. And again, in the Swedish joint registry, it's slightly different. Under 50-year-olds, what you can see, the line in red here, the biggest proportion is actually uncemented hip replacement. While if it was for all ages, then it's cemented hip replacement. So clearly in Sweden, people prefer to use uncemented implants for under 50-year-olds. Now, looking at the data in more detail, what type of acetabular component has better survival? And this is the Swedish registry data. In the age group younger than 50, red is uncemented cup, blue is cemented. So red seems to have slight survival advantage as compared to blue, both in younger people, younger than 50, and the age group between 50 to 59. However, they did not find any significant difference when they did further data analysis. So that's the acetabular component. There does seem to be a trend towards better long-term survival in terms of uncemented component. What about the stem? Again, blue is the cemented stem, red is the uncemented stem, and at around 7 years, it seems the survival of cemented stem becomes worse off as compared to uncemented. Whilst in the first 7 years, the uncemented stem seems to have poorer survival, and majority of that is perhaps because of this, the fracture risk. Yeah, periprosthetic fracture risk in uncemented stem is much higher, especially in the early period, especially in the first year or so. In fact, probably during implantation, and this difference is significant. And then if the implant has survived beyond 7 years, there is certainly a reduced relative risk if you use an uncemented stem as per the Swedish joint registry data. But we clearly know that the Exeter cemented stem actually has excellent survival. And that's not the most commonly used cemented stem in Swedish joint registry. So what about the NGR? A very complex slide here. I would ignore all of that. I would just concentrate on this. I would concentrate on 15-year survival for under 55-year-olds. Yeah. So what you can see here is the NJR data suggests that the hybrid combination is perhaps the best in terms of survival for under 55. Uncemented is actually higher. Part of it is actually probably still the after effect of the metal on metal debacle. And what about the Australian joint registry? Again, if you look at the data here, the hybrid seems to actually perform equally well at around 11, 12 years, but the cementless seems to outperform at around 16, 17 years. But this difference, if you look at the p-values here, is not significant as such. So on the basis of this, in terms of fixation methods, what we had recommended, and this wouldn't change, is you can use a cemented or uncemented combination. You can use an uncemented or a hybrid combination for under 50-year-olds, but still the NICE benchmark may not necessarily be met. And you should consider using it on under 65-year-olds. So what about the bearing surface? The choice of bearing surface, there's the temporal data that has also changed. So for uncemented, what you can see here is that the most commonly used combination is ceramic on poly now. And even for hybrid, the most commonly used combination is ceramic on poly. That's the blue. Metal on poly has slightly increased for uncemented, but very interestingly, the ceramic on ceramic from 2010 to 2019 has completely sort of reduced. It's 1/4 of what it was being used before. So there would clearly be a reason for it. And similarly for hybrid combination, ceramic on poly, ceramic on ceramic is decreasing. Ceramic on poly is slowly overtaking a metal on poly and hybrid. And yeah, perhaps there's a reason for it. So if you look at the revision, the risk under 55-year-old, I'm concentrating on the young group because that's where the problem is. And what you can see is for cemented combination, ceramic, if you end up using a cemented combination, best to use ceramic on poly for under 55-year-old because that does lead to decent survival. If you're going for uncemented, ceramic on poly or ceramic on ceramic, perhaps very, very similar. Um, and if you're going for hybrid combination, again, ceramic on poly or ceramic on ceramic, at least on the NJR data seems to be very similar. But what the NJR data does not account for is the type of polyethylene. And highly cross-linked polyethylene is not yet reported to be different as compared to standard polyethylene, and that tends to cloud the data. And clearly the use of highly cross-linked polyethylene has increased over time. And that's in the Swedish joint registry and the Australian joint registry. As you can see in the graphs here, the most popular combination is actually highly cross-linked polyethylene. The people using non-cross-linked polyethylene are very few. And that if you look at the survival of the highly cross-linked polyethylene in the Swedish joint registry, you can see a significant better survival of highly cross-linked polyethylene as compared to standard polyethylene. And similarly in the Australian joint registry, so 19-year data, around 5% risk of failure for highly cross-linked, but for the standard poly, almost 15%. So there's an argument of using a highly cross-linked polyethylene if you're going for uh, uh, poly combination with either ceramic or metal head. And the Australian Joint Registry has also come up with, this is the most recent one, 2020 data, has come up with survival curves for various bearing surfaces. And what you can see here is at around 15 years, actually, the survival of the oxinium, the ceramicized metal with highly cross-linked polyethylene is much better than any other combination. And perhaps the ceramic on X3 poly, that's the blue, and the metal on X3 poly, again, highly cross-linked poly is still better. So if you're using highly cross-linked polyethylene with either metal or ceramicized metal or ceramic, it will work. But if you're using it with standard poly, then survival advantage is not there. So recommendation as per the review that we did and still stands is ceramic on highly cross-linked polyethylene is probably the best in terms of survival advantage for younger people. So what about head size? This is again the temporal data from NJR. What you can see here is interestingly, even for cemented combination, the 28 millimeter head is actually disappearing. Not necessarily disappearing, but the frequency that is being used is much fewer now. And 32 millimeter is becoming more popular for all combinations. There are obviously some who prefer to use even larger size heads, and there may be, at least in the uncemented comment, there may be slight increase in the use of 36 heads, and even in the hybrids. Obviously, for cemented hip replacement, 36 probably would not be advisable because the poly will be too thin. But now what you can see is the size of the ceramic head is gradually reducing. The frequency of the large size head is gradually reducing. So look at this data. If you're doing revision, if you're doing an uncemented metal on polyethylene, the best combination is 32 size femoral head. The other sizes are actually they don't survive as long. Similarly, if you're using a ceramic on poly with uncemented shell, the best implant survival was actually 32 and 36, and that's the most current NJR data. While the 28 millimeter and 40 millimeter that's a significantly higher failure rate. So I would suggest the 32 and 36 are good size femoral heads to use if you're using ceramic on poly. Obviously, you want the poly to be reasonably thick, so be slightly cautious when you're using 36 heads. If you're using ceramic on ceramic combination, the frequency of that is reducing. Interesting, the NJR data says that the 40 millimeter is the best. So if you're using ceramic on ceramic, a head size of 40 millimeter is perhaps the best. The 28 millimeter had the highest failure rate. 32, 36 millimeter again had the highest high failure rate, and you can see it in the graphs there. There's the 40, and all the others are actually the survival advantage is not much. And but how many times do we end up putting 40 millimeter ceramic on ceramic? I would say very, very few. And especially with squeaking risk, with the advent of the highly cross-linked polyethylene, I think ceramic on ceramic is probably going to, the use of ceramic on ceramic is going to reduce even further. So looking at the Australian joint registry data, they've looked at head size along with the type of bearing surface, and what they say is that this is the blue is the best. Use a 32 millimeter head with highly cross-linked polyethylene, and that's got the best survival as compared to any other combination, whether it's larger than 32 or less than 32. So the recommendation would be that use a 32 millimeter either metal or ceramic head, whatever you end up using, with highly cross-linked polyethylene. But if you want to use it for younger people, yes, ceramic is useful. You can use 36 head as well if you are worried about dislocation risk, and at least on the NJR data, survival is the same. So in summary, hybrid or uncemented for younger people, ceramic on highly cross-linked polyethylene, and perhaps a 32 size femoral head. That's the best combination if you look at all the registry data and most of the studies. We've recently looked at the risk of perhaps revision because of infection in ceramic in various joint replacement combination. We got data from NJR, more than 400,000 patients, 450,000 patients, and we compared various bearing surfaces, and this has been accepted in the Journal of Arthroplasty. And interestingly, the risk of revision for prosthetic joint infection was significantly lower with ceramic on ceramic and ceramic on poly as compared to metal on poly. The reason for this is quite complex. It's probably because of the smoothness and the hydrophilic ability of the ceramic liners. And so almost 25% reduction of prosthetic joint infection if you use ceramic on ceramic or ceramic on poly. But interestingly, even for aseptic revision beyond 2 years, 18% reduction of aseptic revision if you go for ceramic on ceramic, 25% risk of reduction of the aseptic revision if you go for ceramic on poly, and all cause again the same. And this is the forest plot that you can see. Younger people typically do have a higher infection rate and higher revision rate for various reasons, as we've already said. Yeah. So clearly ceramic does provide an advantage in that regard. So what do I do in my standard practice? Keep it simple. Simplicity is the ultimate sophistication. So under 50-year-olds, Exeter Trident combination with ceramic head and X3 polyethylene. Between 50 to 65 in males and between 50 to 60 in males, I'm happy enough to use a metal head. But given the results of the study that I was just quoting, that is being published in the Journal of Arthroplasty, I might just move to ceramic for this age group as well. And over 65 male, over 60 males, just simple standard cemented hip replacement. Thank you very much.
Good. Thank you. Thanks, Ajay. That was really nice, comprehensive summary of what we need to know about the bearing surface, head size, and fixation. And you made it so simple, for the candidates to answer in the exam, and even for the consultants to make a choice as what's happening in the current NJR. That's very good. Thank you. Thank you very much.
Thank you.
So question-wise, I don't think we have any questions yet. But all the participants, if they want to ask any questions, they can put it down in this panel on the question answer thing, and we can get it to the speakers to answer. At the moment, I don't see any questions. Is there any other questions from the other panelists? Mukesh, Birinder, have you got any questions? Okay,
Yeah.
so that's fine. Thank you. Thanks, Ajay. We will now move on to the next talk. And the next talk is also equally important. It's regarding dislocation following a primary hip replacement, which is one of the most kind of dreaded complication every hip surgeon would dread of, because if you see a dislocation after your primary, as sooner you get, you're really worried about it, and you can't hide it. Present in somewhere, and everybody gets to know about it. So we have Mr. Mukesh Amadi, who is one of the very senior consultants in Wrightington, who specializes mainly in hip and knee, primary and revision arthroplasty work. He has extensive experience under his belt. He has done fellowships in USA and Canada. He's also active in other areas. He trains MCH candidates. He also has a post CCT fellow with him, and is the surgical tutor for Royal College. He's on the orthopedic committee for BOA. So he's got a lot of other commitments along with his clinical practice. And he also spends his spare time playing cricket. He finds time to do that as well. So I will invite now Mr. Mukesh Amadi to present his talk on dislocations following primary hip replacements. How do we assess, and what can we do about it? Okay. Thank you, Mukesh.
Thank you. Thank you. Can you all see the screen?
Yes, we can. Yeah. Thanks.
Okay. So thanks for the kind introduction, Prakash, and the invitation to speak at this forum. And I've tried to cover both for the exam point of view and also from the learning point of view. Just an introduction, Mukesh Amadi, I work at Wrightington, and who doesn't know this man? And if you are aware, a commemorative stamp was issued in his memory because his pioneering work changed the lives of millions across the world. And on a nice summer's day, this is what the Center for Hip Surgery looks like. But we're in the north, it's not always like this. So I'm just going to just do the talk in a few blocks, introduction, contributing factors and classification for the exams, how to assess. I'll just touch upon the principles of management in the interest of time and some take-home messages. My talk may be sort of diametrically opposite to Ajay's because I'm more for small heads, as you can see from the talk. So the revision burden from dislocations, it's not small. You can see it's second only to aseptic loosenings. But thankfully, in the British Hip Surgery meeting, we saw a few days ago that the dislocation rates are falling. From our center, from 1962 to 1998, we had 22,066 low friction arthroplasties, and the revision rate was only 0.3%, which is very impressive. And don't forget that this is what they had, not the kitchen sink that we have for every operation now. This is all the implants that were used. And if you can see, primary hip replacement from 1962 to 2006, the dislocation rate obviously is more in revisions rather than primary hip replacement because of various reasons. So what are the factors which contribute to instability in a hip? I've divided it into 5, but in my opinion, the component alignment, offset, head-neck ratio, and soft tissues are the important ones, which we will discuss in detail later on in the presentation. Classification from an exam point of view, you can classify in terms of time, early, intermediate, or late. Late dislocations are going to be a problem for us because people are living longer in the developed countries. Number of episodes, whether single or recurrent, and indeed direction of dislocation, whether it's posterior, anterior, superior. We can also classify them depending on patient factors, surgeon factors, and implant factors. Sorry about the busy slide, but you can see that elderly women with cognitive dysfunction are at a higher risk. Anatomical problems with the hip are at a higher risk for dislocation. And also, some of you who attended the British Society meeting recently will show that spinopelvic imbalance is the flavor of the month. I think they're overthinking matters really. And of course, ours is a craft specialty, so the surgeon skill comes into the equations. The more you do with the same implants, the better you'll get. And that's borne out by various data, really. Now, coming to the crux of it, the surgical approach, soft tissue tension, component fixation, head size, I think they're all important. And Ajay alluded to it in brief in his presentation. Historically, posterior approaches had a higher dislocation rate. This was based on Bernard Morris' paper in the 70s or 80s. Hard hinge approach has the least dislocation rate. Therefore, it's popular in North America, especially Canada. The other approaches also have problems with dislocation, but it's quite low. This is my personal work. I looked at 22 millimeter head through posterior approach, worst combination you can think of. I'm sure Ajay will agree with that. And our dislocation rate was 0.7%, and only half of these came to revision. Later on, we looked at 22 and 28 through the posterior approach in 2018. The dislocation in the 22 millimeters had gone up slightly, but there were no dislocation in the 28 group. So this is nearly 1,200 patients over 15 to 16 years. Historically, this paper has always been quoted by Leunick about the component positioning, but I think it's of historical interest because if I'm not mistaken, this was mainly for posterior approach. Whereas if you see the trochanteric approach or the direct lateral approach, the hard hinge approach, the components are based in neutral position. The inclination of the cup is 45 degrees. The cup and stem are based in neutral orientation. And also we know that posterior approach, the components are antiverted. So it's more of historical interest, that safe zone concept. Coming from that to the soft tissue, it's very important to template before you start the operation, basically to get the center of rotation and the offset. Offset is extremely important. If you get the offset right, the soft tissue tension right, I think you're going to have a stable hip construct. Here you can see we've all been members of the Flying Trochanter Club at Wrightington, and you can see on the left-hand side, that's likely to be an unstable hip over a period of time. I don't do trochanteric osteotomy. I'm a posterior approach man. And also the damage caused by metal-on-metal hip replacement, severe tissue necrosis, and a lot of these patients ended up with girdle stone. Head size has been a hot topic, and Charlie started with 22, but across the Atlantic, they felt the dislocation rate was rather high, so they moved to bigger heads. But we have to bear in mind that the polyethylene wear is more, the frictional torque is more, so the force will be transmitted down the line. This is one of the problems of moving to larger heads. And you can see that when there's a metal shell and a large femoral head, there's not enough room for significant polyethylene. You can see sometimes it can be as thin as 6 millimeters, and we've known fractures of this fatigue fractures of the poly. Same side as Ajay showed, and as you can see, the small heads are dropping. The flavor of the month appears to be the 32 millimeter head, but the snooker ball hip replacements are going out, the 36 millimeters are dropping off. You can see the risk of periprosthetic fracture with cementless cups, cementless implants, and large femoral heads. Just an illustrative example, this lady had a hip replacement 10 years ago, had a fall. She injured both her hips. Unfortunately, the left one is not seen. As you can see on the right-hand side, she dislocated her hip. And on the left-hand side, she had a periprosthetic fracture. So the energy on the right-hand side was dissipated by dislocation of the hip. The femur was spared, whereas on the right-hand side, the hip did not dislocate, but the energy was transferred lower down, and we had a periprosthetic fracture. So you decide which is better. Charlie did some work on head-neck ratio, and he found that 2:1 was the happy medium. And like she had 22 millimeter head, so 10 to 11 millimeter neck, and we have 28 millimeter heads now. I rarely go about 28, and we have 12, 14 tapers. So they changed in 1983 from 12.5 to 10 millimeters. The first 200 were done by Frank. Frank designed all the instruments, etc., for Charlie, and he only recently retired. So there was no CE marking or anything. He prepared them on Mondays or Tuesday, and they were in theater on Thursday. Robleski showed that there's increased range of motion with the reduced diameter neck. Consequently, less dislocations, less impingement, less aseptic loosening, reducing revision by almost 60%. You can see a small intervention leads to such a big change. Coming to the mechanism of dislocation, basically it's impingement and poor soft tissue tension. So if the cup is retroverted, it's going to impinge anteriorly in flexion, and the hip's going to come out at the back. Conversely, if it's excessively anteverted, it's going to flick out at the front. And if there's no soft tissue tension, the femoral head is rattling in the acetabulum, and it's a very, very unstable situation. So classification-wise, they have internal impingement, which is within the components, and external is between the bony components, really. So now you have a dislocated hip. How do you assess it? So you can assess it clinically, radiographically, or intraoperatively. History, if you take a good history, they ask the patient, what was the position when the hip dislocated? What was the patient doing? Was she picking up after the dog? Or was she sat on a settee and watching telly? If the latter is the case, then the component position and soft tissue tension come into the equation. And if it's the former, that's more likely to be impingement. Any change in medical condition, Parkinson's, dementia, multiple sclerosis, etc. And has the patient had any recent spinal surgery? These are all good points in the history. Radiographically, we can assess the cup orientation. In cemented, it's much easier with the biomarkers, and you may need a CT scan for cementless implants. Look at the offset. You can look at the soft tissues by metallic artifact reduction sequence on the MRI scan, and also restore leg length. So this is an example. You can see that the biomarker is convex upwards, so it's an anteverted cup. If you see here, it's going down, so it's a retroverted cup. Sometimes it's like a rugby ball, so it's extremely retroverted. So if it's straight, then it's a neutral orientation. So very important in determining the version. Here you can see the liner is dissociated, leading to recurrent dislocation. So you can get a lot of clues from X-rays. If you see the lateral X-ray, it's retroverted, clearly retroverted. This is abductor insufficiency due to trochanteric non-union, leading to recurrent dislocations. Combination of factors here: open cup, no abductors, worst case scenario. And here you can see that the patient underwent recent spinal surgery, as a result of which is extremely stiff, and a year later the hip starts dislocating. So you get a lot of clues from the X-rays. Intraoperatively, you take the patient to theater, you manipulate the hip, and during that you have to look at a few things. In which direction does the hip dislocate? How easily can it be reduced? What's the stable range? And in which positions does it dislocate? And also make a detailed account of this in the operation note, so that when you hand over the patient to the parent team, they should know what the problem is and they can plan accordingly. So documentation extremely important. Going to management, you have close reduction under a general anesthesia. Bracing is up to you. I tend to brace them for about 6 weeks, old-fashioned, you can say. But the jury is still out on this, really. If it's a tripolar cup and it comes out, then it's very likely to be an open reduction, and you'll have to prepare for that. Surgical options, you can have, you can use a posterior lip augmentation device for low demand patients, dual mobility, and there's a spectrum ending up with pseudoarthrosis. We'll go over this one by one with illustrative examples. We have a lot of options in cementless components, but its supramodularity leads to a lot of problems as well. So I won't go into the details of that because I've got limited time. So this is a posterior lip augmentation device. It's placed on the polyethylene and screwed in. An example, this is an 86-year-old lady, significant comorbidities. We couldn't do a major revision, so I applied a PLAD, and thus far she's not had any further dislocations after 5 years. 92-year-old lady with cardiac issues, and this procedure saw her through. Dual mobility sockets have been a game changer in revision arthroplasty for hip replacement, and they have been extremely useful. And what I would say is, although they're very useful, there are some problems emerging from the French group, really, which was presented in the Hip Society recently. So I've used them in for abductor insufficiency, dementia, patient with dementia with recurrent dislocation, fine for 15 years, but suddenly started dislocating, and people realized she was, had dementia and was placing the leg in awkward positions. So it's been quite successful. And we looked at the results of this, and short-term review results are quite good, but as I said, the French are finding some long-term problems. This is an issue with the offset and version, which has been corrected. Again, extreme antiversion. This surgeon was more used to the hard hinge approach, and when he came to do the posterior approach, he was told that he had to antivert the components, and he antiverted so much that it came out in recovery. So this has been addressed by revising both the components. This lady is interesting. Teacher was told that metal on metal, she can climb Everest after 2 weeks, big head. So open cup, trochanter shattered during the operation, no abductors, 53 dislocations when she came to me. And when the registrar was examining the hip dislocated in the clinic, he was scared to bits. So what I did was I used a tripolar cup for her, and then, as usually happens with constraint thing, the hip didn't dislocate, but it dissociated from the acetabulum. The whole socket came out when she was on holiday. I put a cemented cup with bone grafting, etc., and didn't dislocate for a couple of years. But unfortunately, as always happens, she had a periprosthetic fracture, and I had to revise the stem as well. In hindsight, probably I should have revised the stem at that stage, but it was well fixed. I thought I might get away. So luckily, after about 7 to 8 years, we've not had any further issues with this lady. This was component malposition, both acetabular and femoral, and we had to revise it. You can see the component is pointing in the wrong direction. It should be pointing towards the other end of the room. It's pointing towards us. So it was completely retroverted, and both components were revised. And on the right-hand side, you can see it's a revision, not a primary. That's the advantage of using small components with cement. I have no personal experience with this, but it's described in books. I've seen some of my colleagues too with variable results. Despite your best efforts, if things fail, then we are headed for disaster, and the patient has to be prepared for a pseudoarthrosis. This is a bad situation to be in. And as I said, one episode of dislocation is not a problem. When it becomes recurrent, you could end up in this situation. Basically, this algorithm tells you that look for the problem, identify the problem, and treat it, and you'll get a good outcome, as in medicine. But I wouldn't go for the tripolar cup. A word about late dislocations. I'll be finishing shortly, Prakash. And I think it's becoming an increasing problem with the aging population. You're going to see more and more of these because of component wear, spinopelvic imbalance, neurological conditions. This is a gentleman who had a standard hip replacement, functioning very well until had this horrendoplasty, full of metal, extremely stiff, and a year later, he started having a couple of dislocations. Thankfully, it stopped at 2, and 2-3 years down the line, he's not had any dislocations. So we're just observing him. Again, dementia is going to be a problem. Recurrent dislocation, we'll need all this in our armamentarium. Ankylosing spondylitis, this was done about 10 years ago, no problem, but he's come to me for the other side now, and look at his spine. if I'm not careful, this is going to be a major problem. This is a cerebral palsy, Chiari osteotomy, and I've done him 12 years ago, but I'm expecting some late problems because his muscles are going to deteriorate. As also, this is spina bifida, pre-lockdown, put on the waiting list, lockdown, 12 months later, look at the hip. We've done her hip now, but I'm expecting problems here as well with late dislocations, if not dissociation of the cup. So some take-home messages. So get it right first time. If it dislocates, look for the cause and address it. Don't do revisions for unexplained pain, etc. Intraoperatively, my advice would be minimal soft tissue dissection, optimal component positioning, never put a cup in retroversion. Adequate soft tissue tension, and as I say, stable on table, but it might dislocate when he leaves the hospital. I had the good fortune of working with this great man, Professor Wroblewski, and when I joined, large heads were the flavor of the month. Large head, ceramic on ceramic, large head, metal, metal. And Mike Wroblewski has always been a small head man, and asked him what he thought about it. He said, boy, big heads will not save you. If you can't do an operation properly, this will not save you. Don't do snooker ball hip replacements. Thank you. Thank you for the attention. Any questions, please?
Thank you, Mukesh. That was a very comprehensive, detailed kind of assessment and management of dislocation. You covered even the complex scenarios as well, and these are not easy primaries anyway. And you're right, you know, a lot of cases you would expect that there will be follow-on problems. And thank you for touching all those areas. Regarding the questions, I don't think there are any questions at present for yourself, but I think Ajay has been answering some of these questions on the question and answer box, which is good. I think, yeah, there is one question for Ajay, which we will go at the end of the meeting. So next, I will probably, we're running out of time, so I'll invite the next speaker. Thank you, Mukesh. I'll go on to the next talk now. So we will invite the next speaker, who is Mr. Birender Kapoor. He's one of the senior surgeons at the Royal Liverpool Hospital, and he is mainly practicing now arthroplasty work, including some trauma and also some tumor work. He has set up a regional metastatic bone service at the Royal Liverpool Hospital. I think, yeah, they were kind of pioneers in setting this up, and they provide service across the region for metastatic bone disease. He also regularly does BOA masterclasses for trainees, and he also has active involvement in training registrars in the region. So I will now invite Mr. Kapoor to present his talk on metastatic bone lesions around the hip. How do we kind of assess them, and how do we go about managing them? Birender, time is yours.
Thanks, Prakash. Good morning, colleagues. I'm just going to try to share my knowledge about metastatic bone disease that I've acquired over the last few years. The remit of this talk is disease around the hip. So the whole topic is going to be a little bit limited by the time and the remit, but generally speaking, the principles are the same, managing metastatic disease around the hip or elsewhere in the body. So trying to look at the key learning points for the talk today, I think we hopefully are able to understand the information needed prior to any intervention, looking at the tumor type, the prognosis, etc., the kind of investigations we need before we make our choice. Hopefully bespoke solutions for different tumors and patients, and talk about the intervention options that we have. We're used to dealing with hip fractures. We do quite a lot of that. But metastatic bone disease is completely different to hip fractures for various reasons. So your trauma union rates, you'd expect them to be around upwards of 90%, right? But when you're looking at metastatic bone disease, your union rates with pathological fractures are extremely low. So there is a big difference there. The patients are different. They are poorer hosts. They have chemotherapy on board. They may have had local or regional radiotherapy. So another difference there. The local situation around the tumor, around the fracture, or just the lesion itself is actually deteriorating as compared to fracture, where because of the intervention and the callus formation, things are actually improving. But here, the tumor will be increasing in size. There may be more bone loss. So your implant is actually getting more unstable as compared to the other way around for trauma. And with these patients, as with anything else in life, you only have one bite of the cherry, so you have to get it right first time. With trauma, you may use one method. If it doesn't work, you are able to get back and do something else. But with these patients, they're at the fag end of their lives. So you've got to provide a single intervention which lasts them for the rest of their lives. And then in addition, there are other tumor factors working alongside, which we'll talk about in the next slide. So why are the metastatic lesions painful? Well, it's not just the fracture. The fracture is the easiest, obvious one. If it is broken, it's going to be painful, right? But you can have microfractures, and that, fair enough, you can visualize that. You actually don't see them on CTs, but you can see them on MR scans. But that's another mechanical reason for pain, and we understand that easily as orthopedic surgeons. But what about the tumor size causing periosteal stretch? That's painful. The tumors will secrete various chemicals, substance P, leukotrienes, necrosis factor, the number of factors that are being released by the tumor itself, that causes pain. And the involvement of sensory nerves because of the tumor. So when you're thinking about using an intramedullary nail, all of these factors, the last three factors, you're not addressing them at all. You may address them afterwards with radiotherapy to shrink the tumor down, for example, but the intramedullary nail is not affecting last three factors. So you've got to bear that in mind when choosing your interventions. So which of these pathological fractures around the hip are going to heal? Well, myeloma is a good one. Generally, hematological malignancies respond well to treatment and stabilization. But for example, lung tumors, you have no chance of healing. So if you have a subtrochanteric pathological fracture with a lung cancer, there's no point in sticking a nail down that tumor because that's constantly going to be painful, and it might fail if your patient goes on to survive past a few months, because these days you can't assume that somebody with lung cancer is going to be dead in 3 months or 6 months, because the immune therapy now is completely changing the game. So these patients who are responders, and that can be checked with the oncotype, if they have PD-L1 positive tumors, they will do very well with immune therapy. So you have to assess a lot of factors before deciding. So what are we trying to achieve when we have a patient with proximal femoral mets? It may be a pathological fracture, may not yet be a pathological fracture. Well, you just have to put yourself in the situation. So you're the patient who's got a metastatic disease. What would you like? The first thing and foremost is you want an honest and detailed discussion of options. That's what we do when we talk to them about hip replacements, right? You have to do the same when you have a patient with cancer. You don't want your junior-most member of the team going to the patient in the evening and saying, well, you've got a tumor in your bone, we're going to fix it tomorrow with a nail. That's not consent. That's not honest, detailed discussion about the options available. So we have to be better than that. If you're the patient who's suffering throbbing pain in your thigh all the time, not relieved with anything other than until you're doped up to your eyeballs with morphine, well, you want pain relief. You want that pain to be better. You want to be able to mobilize without pain. Right? So if you've stuck a nail down the femur and the x-ray looks very good, but you're still in pain each time you put your foot down, you're not going to be thanking the surgeon, right? And you want a single operation. You've now got multiple clinics to visit, multiple therapies have been started, a lot of investigations. You want to spend time with your family in the last few months, years of your life. You want a single operation. You want one operation that does the job. That's what the aims of the treatment should be. I hope you agree with that. So So we got to discuss all the options with the patient. We need to know what our options are. Let's have a look at them. So do nothing, definitely an option. It may be you choosing to monitor currently with a plan to go in later if need be, or doing nothing at all. Radiotherapy is always an option. It works well for radiosensitive tumors. It works well in certain situations better than others. So proximal femoral fractures are not great for using radiotherapy, and we end up using this less and less, whereas for pelvis and spine, for example, or ribs, scapula, radiotherapy actually works very well in some tumors. Intramedullary nailing, of course, is an option. Because of the reasons I mentioned, the last 3 reasons of pain, it is actually helpful to excise the tumor or curette it out if you are using intramedullary nailing, because that will get rid of the tumor-related factors causing pain. And it may not be appropriate or possible in certain cases, but you certainly have to consider doing that. And if you are using intramedullary nailing, do consider radiotherapy at 4 to 6 weeks after the wounds have healed. Hemiarthroplasty is an option. Whether you are ending up with a long stem hemiarthroplasty for a proximal femoral disease, it's always an option to be able to excise a tumor or certainly curette it out. It allows you to use a large head as well. Dislocation risks are lower. Total hip arthroplasty is important where you have a longer prognosis or you have involvement of the socket with the tumor. You then have to consider whether you need to use the rest of the femur to be plated because there may be other satellite lesions. Endoprosthetic replacements are very robust methods of treatment. And we tend to use that in cases where other simple arthroplasty is not an option and patients are expected to have good prognosis. We have to remember that cryotherapy and cement augmentation, particularly in acetabular lesions, for example, is an option. It's usually available in teaching hospitals, central hubs, but you have to be aware of these treatment options. And if you don't have that available in your center, you've got to refer them somewhere where there is. And one of the BOOST guidelines is for proximal femoral fractures, you've got to consider arthroplasty wherever possible. And the reason for that is that it takes out the persistent tumor factors out of the equation when you use arthroplasty. So we've looked at the various options available, and now we look at how we're choosing those options. So you can look at patient factors, tumor factors, but let's just talk about surgeon factors. They should never dictate what is being done for the patient. Please let us educate ourselves. Let us know what the best option for our patients is. And if we can't deliver that, we send the patient elsewhere where this correct surgery can be performed, right? So the fact that, well, we don't offer endoprosthetic treatment for the patients and therefore we'll stick a nail down this femur should not happen anymore. So patient factors, the prognosis. How long are we expecting the patient to live? What kind of tumor burden do they have? What kind of solid organ spread there is? And that actually tells us about the patient prognosis. What is their general health? It can be an in-clinic discussion. You're looking at the patient, they're short of breath because they've got lung mets, or they're cachectic. That gives you an answer, right? It tells you what an appropriate intervention would be. Patient might want to be left alone. That is an option which we have to abide by. The tumor factors are basically what the tumor is doing to the bone. So is it lytic? Is it plastic? Is the tumor known to be a slow-growing tumor? So majority of the bone-laying prostate tumors, for example, they are slow-growing. We end up keeping our patients under monitoring for a number of years, and they do not go on and fracture. Or you may have an aggressive lesion like a renal tumor, for example. What has been the patient's response so far to treatment? So if the oncologists will regularly do repeated scans while patients are on treatment, right? And they look at the size of the tumors and how they're shrinking. So if the patient's been responding well, if you've got breast tumors, for example, that are hormone sensitive, then you know that the prognosis is going to be good. Then you have to choose your implant or your operation appropriately. Next is the tumor site. So if you have significant involvement of the tumor where you cannot use stabilization. You can't use an implant like a nail, then you have to change your treatment option. So, you have to have a bespoke solution for each patient that presents to you, for the patient and tumor factors. Now we've worked out how we choose our intervention. When do we use it? Well, that one's easy. Your outcomes are twice as better if you do a prophylactic fixation than if you do it after the fracture. When I say fixation, I mean any of the above interventions, not just a nail. If you're doing it before the fracture occurs, your outcome's going to be better, and that's fairly easy to see. Endoprosthetics in femoral lesions are a very robust method of treatment, and they frequently will not require any revisions, whereas your other methods of fixation might. And therefore, it is an important tool when you have patients who are expected to have good prognosis. You need to consider these. These operations have been in use for a long time. We have we looked at our data, and the risk of infection with these procedures are the same as in our unit, same as with primary arthroplasty. So the old historical figures of 10 to 14% risk of infection is incorrect. So we should not deny our patients these procedures because of perceived risks which are no longer there. The risk of dislocation when you use hemi heads for these patients is minuscule. So, you should not deny them this very robust treatment option if their prognosis is good. So we've looked at what we want to do, but what will help us decide? These are the further information you'll need before you decide. You have to know your tumor. So you need to have certain knowledge about how the tumors behave, and the more you read, the more you work with these patients, these tumors, the more knowledge you acquire on these. But at the time of the presentation, do we have a known primary? You might not. And if you don't have a known primary, you cannot barge in with an operation. You need to know what you're dealing with. You at least need to make an effort. So do you need a biopsy? Can you get an idea from CT chest abdo-pelvis as to what the tumor is? And if you know the tumor, what are the characteristics? So, is this a hormone-sensitive tumor? Is this responding well to previous therapy? You then need local staging. You need to know what the extent of the local tumor is in the area where you can see it. You need to know if there are satellite lesions. So if you choose to do a total hip replacement, but you've got another lesion right at the tip of the stem that you leave behind, well, that's negligent. You haven't prepared properly. So you need an MRI of the femur or a CT. Our radiologists say that they can actually predict very well whether there's likely to be a distant lesion or not on a CT of the femur alone. Or you can do a PET CT, and that will give you equivalent answer of a bone scan, and it'll tell you locally where the extent is. You need to have systemic staging. You need to know the patient prognosis, because that's what helps you decide what intervention you're using. And that you get with a CT CAP, which will give you solid organ mets, your lung, your liver, tell you about the spine. And a bone scan or a PET CT will tell you whether whether there's same bone lesions or other lesions elsewhere. And you have to have a discussion with the oncologist. You cannot proceed to surgery unless you've discussed this with the oncologist, where a primary is known or the patient is under treatment. You need to know what's happened so far. Have they got better with treatment, or they've had 3 different lines of treatment used, the tumor is totally out of control? You'll need to know what's going on. If there's been an attempt to find the tumor, but it remains a cancer of unknown primary, well, these patients do quite badly. In our series from Clatterbridge Hospital, the mortality is upwards of 80 to 90% within 6 months when you have cancer of unknown primary. So if you know that, that'll help you choose your treatment option. So let us try to look at some case studies and see whether we can apply the things that I've just said to our interventions. So here we have a 47-year-old patient. She has 3-month-old diagnosis of CA breast and a very early presentation with metastatic stage 4 disease. So the things going through my mind is, well, it's 3 months down the line, she has breast surgery. Was a biopsy sent? Was a tumor sent? Is she hormone positive or negative? You know, does she have solid organ mets? So what I need is, I need a CT-CAP. I need to look at the liver, the lungs. I need to look at whether it's hormone sensitive, whether she's had already an interval scan to see whether tumor is shrinking or not in response to treatment. So I want to do all of those things because this has not fractured yet, right? Just as a lesion, I've got some time to investigate. So this was what was done in the referring unit. So she's had a femoral nail inserted in the next day's trauma list. And that's okay. You know, maybe we'll try to use radiotherapy at 4 weeks and see what happens. But the bone scan shows that this was the only area of metastasis. So quite a wide area, but there is nothing else elsewhere. So my thinking would be, if I saw this prior to surgery, that I can do a resection there and use a very long segment distal femoral replacement. I've got enough fixation for my stem over there, and then I think this lady would do well for a number of years with a distal femur replacement, if that was done primarily. But so 3 months down the line, she's referred in because she's in agony. She can't put her foot down without pain. She's in a wheelchair and she has throbbing pain in the thigh 24 hours. She's in a high dose regular morphine. She's 47, right? So we have to do something for her. Using radiotherapy alone will not be an option because she's actually a double positive breast tumor. And I know that her 5 years, or at least 3 years survival will be around 50%. So there's a good chance, in fact, it'll be a bit more than 50%, because she doesn't have solid organ mets. So we've got somebody who's going to be alive for 3 years or so. You can't just use radiotherapy and hope that the tumor will shrink and pain will improve. So she had to have a total femur replacement, and she died nearly 4 years after this was performed. So an endoprosthetic in her would have been an appropriate option with a slightly smaller intervention in terms of a long segment distal femur replacement at that time. Now we have an 85-year-old patient. I don't know how well it projects. There is a stress fracture through this tumor here. And you can see that there is, although having said that, the neck shaft angle suggests there is a fracture at subcapital level, but there wasn't one on the scans. So this patient has, as you can see on the MR scan, complete involvement of the proximal metaphysis, right? You can put a nail in there if you choose an appropriately angled nail. I would suggest that would be totally useless for pain control and for any kind of stability. You can do a hemiarthroplasty, and I'm thinking that this patient has got pain, so he's at, the reason why the first X-ray was performed was not because of fracture, it's because he was in pain at rest. So the patient's got a lot of pain. You can use a long hemiarthroplasty, but you will find that all of this proximal bone will have to be resected. So this patient has a reasonably elegant solution with a proximal femur replacement. In our hands, these proximal femur replacements are essentially slightly longer than hemiarthroplasty surgery. They don't bleed excessively, and they have very low rates of dislocation, and they are immediately relieved of the throbbing pain that they have. So this was the treatment option, which was most appropriate one for this patient. We have to talk about hematological malignancies because they are quite common and they have to be treated slightly differently. So this is a 72-year-old male with a new diagnosis of multiple myeloma. He also had some spinal lesions, so was referred to the spinal team first. And this X-ray was done in the spinal clinic because the patient had some hip pain. The spinal registrar failed to notice that. And this patient was sent to our clinic 3 months afterwards with this kind of lesion. So you can see the iliaceal line is disrupted, iliopectineal line is disrupted. This is quite a large lesion there. But it is multiple myeloma, and the patients had recent start of multiple myeloma therapy. So if you go in now, you'll be faced with a very cheesy texture of bone, a lot of bleeding with very difficult reconstruction options. But these patients do not need that, right? What they need is monitoring. What they need is denosumab. They need to have bone protection, and they need to have their multiple myeloma therapy. So we have upwards of 12 patients currently in our series with acetabular lesions around from myeloma with conservative treatment, and they tend to do well. And none of them has gone into protrusia so far. But it needs to be directed therapy because you know what the diagnosis is. Here's another example. So a 55-year-old male who has 3 different cancers. So he had bladder and a testicular tumor, and there was something else that I don't remember now, but he had a femoral neck fracture, and he was very disappointed that he was going to die very soon, and he got really depressed, so he chose not to have any surgery done for his femur. And that was not very painful. But then he presented 10 months afterwards with a lesion which was now throbbing. So he was in constant agony with this lesion. It was driving him mad, and he realized that he wasn't dead yet. He thought he was going to be dead very soon from the cancer, but he's still alive and he's in pain. And this kind of tumor, that's what I was saying previously. If you have throbbing pain from a lesion, if you just put a nail down this, he will still be in throbbing pain. And whether this tumor improves with radiotherapy or not, you won't know. But then you've already done your treatment, and then you won't know whether it gets better or not. So a bespoke solution for this patient was arthroplasty and plating. And he had curettage and cementing of this tumor. So this patient went on to live for another 2.5 years after this intervention. He was able to mobilize. So, horses for courses. You have to decide based on the tumor, based on the patient, as to what your appropriate options are going to be. There are some special situations. So I'm aware that when you have a pathological fracture, you feel obliged to act quickly. Well, you have to. You have to acquire all of the information that we discussed before much more rapidly. You have to get on the phone to the oncologist. You have to get your investigations done same day, the next day, so that you can get as much information as you want to make your decision. And if you do not know what the tumor is with the pathological fracture, you don't go ahead and nail it. This may be a primary bone tumor. The patient won't thank you, and your hospital trust won't thank you for the medical legal case that ensues for you having treated somebody very rapidly, right? You may need to do a biopsy before treatment. So when you have a new diagnosis, obviously, somebody's presented with a lesion, you don't know what it is. You have to find the primary. You cannot proceed to treatment unless you know what tumor you're dealing with. You may need various investigations. You may need biopsy. And if it is a cancer of unknown primary, that will dictate what you do for those patients for the reasons I mentioned before. So hopefully, we've been able to look at the kind of information we need, the different treatment options we have for these patients, and how do we decide those different treatment options? Thank you.
Thank you, Varinder. That was a nice talk, good summary of what to look for and how to manage. I think it's probably very important, for the exam and also for the day-to-day practice for most of the orthopedic surgeons, because we'll probably come across this definitely in our clinical practice, and that was a good outline of what to expect and what we can do. Thank you. Thanks, Varinder. We have a few questions now. I think there is the first question. I think I have to put it to Ajay because it's addressed to Ajay.
Hi.
Question is, hi Ajay. Hi. The question is there any literature or evidence to suggest what is the minimal thickness of polyethylene we put in, or is it just an arbitrary figure?
So literature from memory, I think it's around 8 millimeters or so, isn't it? From memory, I'll have to look into the details, but there should be enough thickness of polyethylene, at least if you're talking about highly cross-linked polyethylene. Now, if you're talking about standard polyethylene, which, as you know, reuse is declining. But if you're going for a cemented polyethylene, there have been several studies which have shown that the diameter, the ideal diameter of the polyethylene cup should be double the size of the diameter of the femoral head, and that will give the longest survival. But that longest survival would mean millions and millions of cycles, more than 50 years. Yeah. So, so if you're putting a 50 cup, an ideal femoral head is 25, and that will give the longest survival. But then that has to be balanced with the risk of dislocation and other problems. Yeah. So, yeah, that's what I'm currently aware of. But the highly processing polyethylene is around 8 millimeters from memory.
You would say that don't go below 8 millimeter in thickness for any type of polyethylene.
I would check that again, but it's around 8 millimeters. Yes. You don't want to go thinner. It will be a problem in the long run, especially for if you're looking at younger patients. Then it needs to survive their lifetime, and that should be the ultimate goal. May not be possible, but yeah, it should be as thick as you can make it. So, which is why you may want to actually not go for 36, 40 size femoral heads to make sure that the polyethylene is thick enough to survive as long as it can.
Thank you. Mukesh, you want to tell something? Your hand is up. You're muted. You're muted. Mukesh, we can't hear you. No, we can't.
Prakash, can I ask a question while Mukesh sorts out his
Sure,
audio?
sure. Yeah, yeah. Yeah, go on, go on.
Ajay, I wanted to ask you, is there coming more evidence now for use of lip liners? So the elevation, local elevation of the liner that we use with uncemmented shells. There was a time when a dial-a-prayer, as it's called, it was thought to be a bad idea. The results were poorer, but I think recent data is showing that the dislocation rates are lower with the dial-a-prayer liners. Is that correct?
So there was some research published recently, and actually was presented in the British Hip Society meeting from Wrightington, looking at NJR data and looking at the 10-degree liners as opposed to 10 or 20-degree liners as opposed to neutral liners. And in an uncemented combination, what they recommend is you should probably be using 10 or 20 degrees. Yeah. And it's got better survival advantage as compared to a neutral liner. But if you are doing a cemented hip replacement, then apparently the one without any lips actually is better, and because of the risk of impingement. Now, why exactly is it different for cemented as opposed to uncemented is difficult to understand.
Yeah, there may be individual factors of that particular implant which are also at play, right?
Yes.
Thank you.
Mukesh, is your
Can you hear? Can you hear me?
You now?
Yeah.
Yeah.
It automatically goes into mute. I mean, coming back to Ajay's point, the work was done by Charnley. The cup size, if it's twice the size of the femoral head, it does well. So in our series of more than 60,000 joint replacements, with the 22 head, the 43 cup did the best in terms of wear and longevity, and over 40 years. So yeah, 2:1 is the happy medium. It's a holy grail, really. So my worry is that with all these large heads, you're getting very thin poly. Some of the papers recommend 6 millimeters, which I think is very, very thin. You can see daylight through it. I'm worried about fractures of these poly, really.
Because in the end, highly cross-linked polyethylene is slightly more brittle, isn't it? Which
Yes,
is why it's not used for knee replacements.
Correct.
So one needs to be mindful of that.
Yeah.
Okay, so there's one more question for Ajay. It reads, why do you use cemented stem in under 50s when the registries and literature show the survival of uncemented stem is better? This is put across by Mr. Rao.
because it's got 99% survival in young people at 20 years and even beyond. That's why. And then yes, the Swedish registry and Australian registry do suggest sort of uncemented combination to be slightly better, but they haven't really looked at Exeter stems properly. But Exeter stem is excellent.
Okay, great. There's
And
one
it gives
question
you so
for.
many advantages, so many options as well, actually, in terms of offset correction, rotational correction, and so many other things. It's a versatile stem, easy to put in, and has got probably the best results amongst all stems available.
I think I agree with you. Next question is for Mr. Hamadi. The question is, when you are assessing recurrent dislocation, do you assess regularly or in every patient the pelvic, spinal pelvic alignment? Do you assess the pelvic tilt and pelvic inclination in relation to the cup? And is it required for every case? And there is another question by the same attendee, that what is the role of constrained cups when you're not sure what the cause for dislocation is?
Right. I mean, the first question, I think, yeah, we obviously in the recent British Hip Society meeting, the spinopelvic imbalance had almost a session. I do feel that we may be sort of overthinking the problem. I do look at patients with scoliosis, and the one that has to be taken care of is the person who's got had a fusion recently. That can cause problem, but you can't account for that. But no, I don't measure all the angles. I think it'll be death by angles, really. So what is the most important thing is the version of the cup, isn't it? The combined version. So are you going to antivert a lot? In that case, the anterior wall gets exposed and it'll impinge on that, right? So what I tend to do is to put the cup closed and give the normal antiversion. What I take care is to see that I put a slightly high offset stem, which will prevent impingement. I think that's all I've done so far. And thus far, I mean, I have to say, touch wood, I've not had any dislocation in this group of patients. I mean, maybe I'm speaking too soon, but I think the important thing is the offset. If you put a high offset stem, you can sort of future-proof it in terms of impingement and dislocation. I don't know what the second question was.
Second question was, so when you're not sure what the cause for recurrent dislocation is,
yes.
You get in some cases, do you straight go and put a constrained cup, or is there something else you consider?
Well, I mean, of late, it's basically the dual mobility cup, really. That's what I'm trying to go. I think constrained liners are out, really. Tripolar cups are out because we have seen so often that the hip doesn't dislocate, it dissociates from the acetabulum. It comes out as one single mass. So we rarely put tripolar cups. So we do use a lot of dual mobility cups, but if we can identify a cause, I think we should address that. But dual mobility cups are game changers. Is a game changer.
I think, yeah, that's yeah. Thank you, thanks, Mukesh. I think that's all the questions we have. I don't think.
I think
Anand
Divekar. I saw Anand Divekar in the chat. He wanted to ask something.
Do you do cemented cups and stems for all cases? That's the question.
Yes,
Anand
I do.
asked.
Yes, I do. Yeah.
That's the question. No, yeah, it is probably you do all that. Yeah.
Yeah.
No, there was no.
Can
I don't
I
think it's
ask you
asked.
a question, please, Mukesh?
Yeah.
Some of your examples were brilliant. Yeah. For dysplasia type situation, you're still doing cemented cups, isn't it? And you've augmented it with bone, and obviously used a couple of screws to fix it, to fix the strut on the this plastic acetabulum. Have you ever thought of using trabecular metal? And because that's obviously something people are using a lot of, isn't it?
Yeah, I mean, I have started using augments in certain cases where the femoral head is cystic. Then I can't use that as a graft. my preference is in young patients to use their own bone. But if the head is cystic, I have been using trabecular metal augments.
Okay. And if you're using the femoral head, how do you prepare it? Your technical sort of.
Yes. So what I do is like where the dysplastic acetabulum, where the head is articulating, I mark it before I dislocate. I take a sector. And when I dislocate, I cut a sector when the head is in situ. It's difficult outside to take a sector. So when the head is already there, you take a sector and then you shave off the base. So this part, which has been articulating for years with that area, fits nicely. So I take a dental burr and burr it and make some drill holes. And now I use only one screw. With biomechanical studies, we found that if you put 2 screws, it can fracture the graft. So
Yes.
I use one screw directed at the sciatic buttress using, and I do the posterior approach. I use the greater sciatic notch as a guide and direct the screw in that area. And that sciatic buttress is the strongest part of the pelvis. And one screw, we can really rock the pelvis. That's how I do.
What size screw do you use? 4.5 or 3.5?
6.5 cancellous,
Okay.
distally threaded, and usually it's 40 or 45 millimeters.
Okay. Good.
Yeah.
Thank you.
Okay, thank you. Any questions from any panelists? Okay, so I think we've covered all the questions and the topics. So I think we'll get this meeting to a close now. I would like to thank all the attendees for attending and all the panelists for their time on a Sunday afternoon. I know it's nice out there and you spared your time to come here and share the experience. I think it was very useful, good tips for the examiners and all exams, and also the consultants in the day-to-day practice. So I would like to thank all the panelists individually, Mukesh, Ajay, and Virender for sparing your time. And I'll get this webinar to a close now. Thank you.
Thank you. Thanks.
a lot.
Yeah,
Thank you.
enjoy the
Thanks.
rest of the weekend. Bye.
Thank you. Thank you.
Bye.
Bye.
Bye.